and welcome to episode 168. Very excited to have Dr. Brian Ahmedani speak to us about zero suicide implementation and outcomes in health systems. We saw a little preview of that, as well as some key quotes that will come back to us. So let's move forward because we have our again, make sure that you all check out talk.crisisnow.com. You can register for the jam here. Again, remember to tell your colleagues to sign up so that they are using their own link. You can get the virtual backgrounds. If folks were on camera, you'll see we have lots of 988 backgrounds, and you can get those here. Sign up for weekly reminders, past videos. You can see previous jams. You can go to YouTube and watch them embedded, or if there's something that you want to pick out of like, hey, there was a crisis jam question, hot seat question that I remember and I want to go back to it, the segments are spaced out there, so make sure that you check that out. And then we have had over 400 unique speakers since this has begun in 2020. We're just talking before it started that this is sort of like the fifth fiscal year, fourth year, calendar year, but we've had so many unique speakers. Hopefully you will see your name in here. And if you don't see your name, please let us know because we want to hear from you. We want to get your idea. What is this?
So we lost Laura. Mike Hogan just making sure that Laura is frozen on. Okay, she's back. There we are. Laura, we lost you for a moment.
Okay, sorry about that. I thought, okay, well, hopefully you won't. I am still on the 400 unique speaker slide. So if we could push forward, unless my computer just needs to catch up. Okay. And so NatCon is coming up. That's April 15th through 17th in St. Louis, Missouri. And then right before that on Sunday is the Crisis Services Summit as well. So if folks are going to NatCon, would love to see you at both. Unfortunately, I won't be there, but NatCon is such a great conference. We're bringing folks together to talk about mental well-being and suicide prevention and everything happening across the states. So hope to see folks there. Next slide. Lots of conferences coming up. There's the SAMHSA 988 Behavioral Health Crisis System Transformation Grantee National Conference. This has been this will be the first conference in maybe over a decade where folks are really coming together, led by SAMHSA, of course. Vibrant is happy to be a partner with SAMHSA and help support individuals from the 988 contact crisis centers to participate. I know other organizations will be there and stakeholders, state policymakers, commissioners, really to talk about this big change that we're all working through. So if folks aren't or don't have that on that radar, make sure that you check that out. Another conference, the Zero Suicide 5th International Summit in Liverpool. The registration link is in the chat. This is going to be another jam-packed conference. We have, I think Sue Murray is going to be attending. You can see here that you can become a sponsor. You can register. Of course, you can always see the Beatles. And in addition to that, right, there is the Zero Suicide Liverpool conference. There's other match opportunities for that Monday and Tuesday. Then we're going to head over to the Netherlands for the Global Leadership Exchange. You don't have to attend both. You can attend one. Obviously, attending both would be great. And then that Saturday and Sunday, the Crisis Now in Amsterdam, Crisis Now 3 Match Summit. So lots of events happening. Make sure that you register for them. Make sure you take a look at the email that was sent out. There's a brilliant case so that you can build the case for your boss or organization of why you should attend. But it is going to cover things like dispatch, ambulance, acute psychiatry as first responders. What does that look like? So make sure that's on your agenda. You can see the sponsors there. And so getting back to our quote for the day, coincides with the YouTube video. It's going to lead into our future presentation. But this is a quote from Dr. Don Berwick, and this is a very famous quote, part of the campaign to save, I think it's 100,000 lives back in 2004. I'm going to read the whole quote for you, but again, you'll see here highlighted in yellow the piece that folks really took away here. Maybe it's the hope that I find in your work every single day to improve care. You're doing so much so well. You're putting the actual transformation into the reach, within reach, and we need to grab it. I'm losing my patience. So here's what I think we should do. I think we should save 100,000 lives. And I think we should do it by June 14th, 2006. Some is not a number, soon is not a time. That time for discipline has come, the time for getting the job done. And I think this just illustrates, and I'm sure Brian, our featured speaker, will talk about this some more, but again, just putting that concrete parameters, right, on that. Some is not a number, soon is not a time. We can save lives. So before we get to our feature presentation, I'm going to bring in Dr. Mike Hogan, fellow Buckeye, who also served as the Commissioner of Mental Health for New York State, to the hot seat. Mike, how are you doing today?
Good, Laura. Thank you.
Good. Well, thank you for joining the hot seat. Zero Suicide 5 will convene in Liverpool in the UK, June 24th, 25th. We just reviewed that. It's a movement that believes healthcare can make a difference and no one should die alone and in despair. Again, highlighted quote. So who originated that phrase? No one should die alone and in despair. You want to talk it through?
Well, it really does summarize what our commitments should be. And here we have a choice among four transformational leaders in the suicide prevention space. Jerry Reed, whose leadership goes all the way back to the Reno Conference in 1996. Becky Stoll at Centerstone that you cited before. Eduardo Vega, who's one of the core leaders of the lived experience movement. And the late, tragically, Dr. Jan Mokkenstorm of the Netherlands. And I think I remember Jan making this comment that David, of course, immediately picked up on and shared with many of us. So I'm going with D, Dr. Jan Mokkenstorm.
Yeah, as you just noted, Mike, there's so many great leaders that were outlined. Looks like 45% of the audience agrees with you, although Dr. Reed is in a strong second at 32%. We don't have a lot of comments in the chat. So again, if you have any insight, feel free to put it into the chat. Mike, are you feeling confident? Would you like to bring up anyone else to talk this through, or should we just go right to see how you did? Is this your final answer?
I think it is, to save time. I might be right or I might be wrong, but yes.
All right, well, you are not wrong. It is Dr. Mokkenstorm, who spearheaded the Zero Suicide 4 in Rotterdam in 2018. And his passion to move beyond the tipping point will continue to serve the global learning community long after his passing in 2019. So well done. Thank you. And thank you for all the work that you've done. You are also a legend in this field. So with that, it's a great segue into our featured presentation by Dr. Brian Ahmedani, who is with the Henry Ford Health Organization, to talk to us about zero suicide implementation and outcomes. Brian, I'll turn it over to you.
All right. Thank you so much for the invite. It's really a pleasure to be here today on the Crisis Jam. First of all, I want to tell you a little bit about zero suicide and how we implemented it across several big healthcare systems across the country. The work itself was supported by grants from the National Institute of Mental Health, specifically. And then we also, I'm going to reference a few things that were funded by SAMHSA, Blue Cross Blue Shield of Michigan. Really want to recognize all the people that worked really hard to make this possible, especially some of our scientist colleagues across 6 different healthcare systems in different parts of the country. and really all of the healthcare systems, health system leaders, clinicians, and patients who are dedicated to suicide prevention and to making this work possible so we can keep moving forward. So just as a background, I think probably most of you know this information, but I'm just going to kind of set the stage for where we are. Suicide is actually one of the top 10, I think it's 11th now, but one of the top leading causes of death in the United States and the #1 cause of injury-related death. We're pushing up towards 50,000 people a year who are dying by suicide, almost 15 per 100,000 people in the United States are dying by suicide each year. But that is just the beginning of the problem. That's what we see at the tip of the iceberg. What we don't see often and what we don't talk about is all the other people who are affected by this personally, and then even by extension in their families and with their loved ones and friends. So almost 2 million, 1.7 million people a year are attempting suicide. It's likely more than that. We don't have documentation on a lot of the suicide attempts that happen, and well over 10 million people a year have suicidal thoughts, adults. If you think about that, that's actually about 5% of the entire US general population of adults in the US that have thoughts of suicide at any given time during a year. That's a big number of people. So this is a pretty big problem. And the other thing that's pretty remarkable is that our US suicide rates have not improved. They're pretty much, they've been increasing. It's the only one of the major leading causes of death in the US that has had rising rates over the last 20 years, couple decades. Most of the major leading causes of death outside of COVID for the last few years has actually experienced a declining or stable annual rate of mortality. So we're not only talking about something that's a major national concern, but also something that continues to get worse year after year after year. We did have an improvement in 2018, 19, 20, but spinning out of COVID, we've once again seen an increase in our suicide rates in the United States. What we have learned over the last 20 years, and unfortunately it took that long, but we have learned that healthcare systems play an incredibly important role in suicide prevention. So we published this study 10 years ago now. It's hard to believe it's been that long, but it is actually the kind of foundation for a lot of the work that we do. And what it shows here, you're just gonna have to trust me on these bullets, is that pretty much most people have healthcare visits in the year, in the weeks and months leading up to their death. Ironically, most people do not have a mental health diagnosis. Only 45% of people have a mental health diagnosis. Most of those healthcare visits are happening in primary care or other medical settings, and only about 1/3 of people ever get to behavioral health services before they die by suicide. Only 5% of people ever get to inpatient psychiatry. So where we target a lot of our suicide prevention work is often in behavioral health services. But if we did that, and we couple that with the fact that the rates have been rising by 25 to 30%, if we only did things in behavioral health, we would necessarily only be able to really flatline the national suicide rate. What we really need to do is think more broadly about the entire healthcare system and how the healthcare system can play a role in connecting with other community sectors across our areas to provide suicide prevention and care. The healthcare system has to be the core. So we always have to have a partnership with a healthcare system in order to extend outside. And that's why it's so important and so vital. But most people are making these kinds of visits, and we have an opportunity to do something about it. Next slide. So just as a history of zero suicide, you heard the quote earlier from Don Berwick, and that actually stimulated the idea of creating perfect systems of care for people with diseases. Back at that time, we thought that suicide was really a factor of depression. It was a symptom of depression. That was basically an understanding. So our program was called Perfect Depression Care. It started at that time. It later became Zero Suicide. When we decided to pursue developing this perfect system of care, Henry Ford created all sorts of different, care improvements, and many of them were based on all the evidence we had available at that time, which was very little about risk of suicide. And it was one of our nurses who said that suicide, that if we were providing perfect care for people in behavioral health, that we would have zero suicides. That's how Zero Suicide started. That's where the name came from. And so it was from then on that it really became a Zero Suicide movement that transitioned into a national program when we talked about the National Action Alliance. SAMHSA picked up that support, also partnered with SPRC. The health and then healthcare systems started implementing these programs across the country, and an international movement spawned that we already talked about earlier with the Zero Suicide International Summit. We can keep going. So we decided to do a study, and now I showed the data in the last slide. If you didn't see it, you could see that Henry Ford had about a 75 to 80% reduction in our suicide rate in our behavioral health population after implementing this program. It was a series of care improvements that included many of the things we talk about today, and has continually added on many of the evidence-based practices as they've been developed over the last 20 years or so. So we developed a national program in partnership with 6 healthcare systems, Henry Ford, plus 5 regions of Kaiser Permanente. And all of these systems decided to implement zero suicide in their patient populations across their entire health systems in different ways. That some of them did it, chose different interventions or approaches. Some of them chose to do it in different settings. Our job was to let the healthcare systems choose how to do it. We then worked with them to develop the measures and metrics to actually measure the outcomes, that not only the processes, whether they did what they said they were trying to do, but also the outcomes of impact on suicide attempt and death. So I show you here a few of the clinical components that we are measuring, things like screening, carrying contacts, follow-up, care and care coordination, safety planning, and connection to behavioral health services. We used an innovative data resource that was supported by NIMH called the Virtual Data Warehouse as part of the Mental Health Research Network to be able to measure consistently across sites all of these different data sources using electronic health records, claims, and specifically Epic. We also linked out to state and federal mortality records to have actual cause of death. We can keep going. So after we worked with all of our health system partners, we were trying to figure out what everyone was doing. And so after we worked with them, we started documenting all the things that they were thinking they were doing for zero suicide, their implementation plans. And what we came to was a pretty consistent suicide prevention care pathway, which started with suicide risk screening, triage for positive screens to get a suicide risk assessment. People who had a suicide risk assessment got a safety plan. And then we supported that entire infrastructure with care coordination and connection to different kinds of behavioral health services or other kinds of care as needed. And that was a cyclical process. There are other parts of this, but that was the general care pathway that could start in any setting, and that could then cascade across the entire healthcare system. And in a way, you can think about this even extending outside of healthcare systems. That's not what we did for this study, but you can think about screening or identification happening anywhere and then connecting into a healthcare system in this manner. We can keep going. So after implementation, and we let them choose how they were going to do it, so that everybody had slightly different protocols. What we found is that implementation in behavioral health, the top row of graphs there, led to a pretty good uptake of suicide risk screening over time. And we wouldn't expect 100% of people to get screened. Some people have multiple visits in the same day. Some people have, cognitive concerns, all sorts of different things going on. So the fact that we got over 75 to 80% in some systems, close in some of the other ones, meant that we were identifying pretty significant increases in suicide risk screening among our entire behavioral health populations. And graph B, you can see that when we did a suicide risk screen, if someone was positive, almost all the time we were doing risk assessments, and that's really good. And that last box C has to do with safety planning and or means counseling, which we measured. And basically most of the time we were doing that as well. So you can see how that cascades. Most people are getting screened. If they screen positive, most are getting a risk assessment. If they get a risk assessment, most of those people are then getting a safety plan and means counseling. And primary care was a little bit of a different story. So what you can't see here is that these health systems had 10 million patients per year. So when you talk about 0% at the beginning, and then you're pushing up towards 10, 12, 13% of the population getting screened in graph D, that's actually about 1 million people. So we really increased screening quite a bit, even though the numbers of people were getting screened, even though the percentages weren't exactly what we wanted. When you look at graph E, you can see though that once we did do the screening, if people were positive, that at least a couple of the systems did a really good job of doing risk assessment most of the time. And if they did risk assessment, then they also did a safety plan and means counseling. Some of the systems didn't have protocols to do risk assessment. They just went straight from the screening to the means counseling and safety planning. So that's why you see lower rates at some systems and other systems that haven't even done it at all in here. So what we saw was really good uptake in behavioral health and pretty good uptake in primary care, although we wish the screening rates were a little higher. A lot of that is the artifact of how they designed it. Keep going. So here's the results. So what we saw in behavioral health, significant reductions in suicide attempts and deaths across across health systems A, B, and C. System D actually is an artifact of measurement. We found that they weren't capturing a lot of the suicide attempts that were happening prior to implementation, and that their coding and identification became so much better after that. A lot of that stabilization there is mostly to do with measurement. System Y implemented in 2012, and you see a consistent reduction in suicide attempts immediately after implementation. System Z is Henry Ford. We have the lowest suicide attempt rate of anybody there, rivaling in our behavioral health population and lower than the rate in the general population in the US. You can keep going. So all of that work tells us that this is actually working. On 10 million people a year across all of these healthcare systems, we're pretty confident that the Zero Suicide program works. We have even more data showing that it worked in primary care settings. I don't show that because all these papers are under review. So they will be coming out later this year. This is kind of a pre-showing of the data. What I can say is that all of this has led to and stimulated a lot of other work, including MyMind, which is now a statewide collaborative quality initiative across Michigan, which includes implementation of our Zero Suicide programs in every single healthcare system in the state of Michigan, covered by insurance and supported by quality improvement across an entire network in the entire state, which is the first ever of its kind. I also mentioned Zero Suicide International, which is our international effort. Please do join us at the summit if you are available. SAMHSA, that's a program that's taking these same principles and expanding them in emergency departments and hospitals. So I wanted to showcase that as well. And we can keep going. So overall, I think the point here is that we saw a pretty significant reduction in suicide attempts and deaths across sites, across health systems, and we're really encouraged. And I think given the widespread implementation, we feel like these data are doubling down on the support for this program moving forward in healthcare systems within the US. And I will stop there. I think I'm passing it off to Mike.
Yeah, well, that was a lot of information. Thank you. Let me just start there. And a lot of good data. And I see some conversations, questions, and links in the chat. But for our roundtable, let me bring in Dr. Hogan and let me get your reflections. Any questions, comments, reflections that you want to share with us, Dr. Hogan?
Thanks, Laura, and thanks, Brian, for cramming a lot of great information into a brief period of time and for doing a really remarkable study. One of the things probably that has held us back a little bit is the absence of definitive, proof that this stuff works, even though by now all of the different components that go into zero suicide, whether it's screening or safety planning or treatment or follow-up, there are individual research studies where they're all demonstrated to be effective, but there are still naysayers and people who look at the old ways of doing things that are failed. And this was really an innovative research project that also you made it sound pretty straightforward, but it's really hard to do this kind of research, even though the numbers of people dying by suicide are stunning. In any one system, healthcare system, those numbers are relatively small. And in order to show a reduction, you've got to have big numbers. And so this method of looking at attempts and deaths within individual systems with some flexibility in how it was done, coupled with rigor in the measurement, it's really a great study. And I think it's going to advance the work quite a bit. I should also say that, as you said, Brian, the participating health systems are all part of the Mental Health Research Network, which is this unique structure supported by NIMH that provides a little bit of support for ongoing research on topics including, but beyond suicide, across these big health systems that enables more reliable data collection and so on. So the suicide prevention is really the one area where the National Institute of Mental Health, which is usually kind of in the genome space with really basic science, but with good leadership, suicide is the one area where they've engaged in practical life-saving research like this study. So it's doing the study is remarkable, and the results confirm everything we've expected about doing this right. I think it's useful to reflect on how far we've come, because it's been, I don't know, probably 10, 12 years since the official launch of zero suicide per se, longer than that since the Henry Ford program. And if you look at the adoption of these practices as a behavioral health innovation, it's been remarkably successful. It's moved quite fast compared to most behavioral health innovations. The best estimates, which are, it's tough we have to rely on estimates, is that are somewhere in the range of 2,000 healthcare organizations in the United States that are doing zero suicide. And that's a faster rate of adoption of this innovation than for most behavioral health innovations. But I go back to the comments at the beginning about no one should die alone and in despair, and that some is not a number and soon is not a time. And if you look at that and you realize the growth in both the rate, the numbers of people that are dying, our progress, which looks pretty good if we just think of this as an innovation, looks pretty bad when it comes to what has to be done to really save lives. And there are a number of things that have really advanced the cause. The work of the Zero Suicide Institute, Brian, your work, SAMHSA grants to implement zero suicide to both states and to providers. The requirements of the Joint Commission, which parallel this, of course, apply to hospitals, have made a big difference. And then CARF has upped its requirements as well. So all of those things have helped, but it's not enough. It's just not enough. And there are still big obstacles. There's no national mandate. There's no CMS requirement that's national with Medicare or Medicaid to really do anything about suicide. So what we've got is grant programs and voluntary efforts. So what CARF has done and what the Joint Commission has done were done by those organizations. They weren't done because of any national expectation. And even though the uptake to 2,000 organizations is pretty impressive, there are probably 65,000 healthcare organizations in the country, depending on how you count them. And so the paradox is this is, on the one hand, it's impressive. On the other hand, there's still 50,000 people dying alone and in despair, and it's just unacceptable. And so we've got to change our expectations with respect to taking this more seriously. We've got to make financing for key activities, for example, follow-up contacts, which are demonstrated clearly to be effective and were part of the implementation in most of the programs that Brian discusses, are often not really covered by anybody. In primary care, which is still, as Brian sort of emphasized, where the biggest numbers are, we still have the U.S. Preventive Services Task Force, which has got its head in a dark place, the way it did with depression 20 years ago, when it said, if you have resources lying around to treat depression in primary care, then you ought to look for it. And that sort of corresponds to their position on screening and brief interventions for suicide. So just to summarize, this is a great research project, a transformational set of results that I hope really advance the cause, and a reminder to all of us that we still have work to do.
Yeah, thanks for that, Dr. Hogan. A good reminder. And I think that financing piece is a big one there, making sure that there's a way to cover this. I'm going to ask for Dr. Richard McKeon to share any thoughts that he may have. Dr. McKeon, are you with us?
I am here. Can you hear me okay?
Yep, we can hear you.
Okay, so I'm in an airport, so I'm going to try to be quick to minimize the ambient noise, but just a couple of quick things. I think the Henry Ford healthcare system and Brian and everyone really deserve a tremendous amount of credit for showing what is possible, for breaking some of the myths about what's possible to do preventing suicide in healthcare systems. This, I think, has been a tremendous and important achievement. Also, the other thing I would want to mention, SAMHSA is very glad to be supporting our Zero Suicide Grant Program. One of those grants currently goes to Henry Ford to embed suicide prevention, screening, safety planning, follow-up across all the emergency departments in the Henry Ford healthcare system. And of course, the emergency departments are crucial. They are the point of intersection with the crisis system. And while, of course, we're wanting to minimize people going to emergency rooms, some number of people will. And so along with primary care and behavioral health care services, the emergency department is hugely important for suicide prevention. And once again, the Henry Ford healthcare system is a leader there. And this is also an area of interest that's part of the White House's military and veteran suicide prevention strategy, which is to take evidence-based suicide prevention, the activities, screening, safety planning, and follow-up that were shown in the ED Safe and Safe Vet studies to be effective, and to try to promote them into community emergency departments around the country. Full order, but an important area of ongoing work. So thank you for the opportunity to make a couple of comments.
Yeah, thank you, Richard. You raised a couple of excellent things there, but I'm going to have David share some reflections for us as well. David?
So Laura, look, suicide is such a wicked challenge, and it's easy for health systems to have kind of a fatalistic view that there's just not much you can do. If, again, Stephanie was referencing, if someone has made the decision to end their life, how can you stop that from occurring? And I remember Richard, Mike, we were all in the room when the Henry Ford Health System told their origin story. And Dr. Don Berwick, who decided to take on quality improvement in healthcare and went to the gurus. He went to Motorola, he went to Toyota, who created a level of robust performance improvement we've never seen. And he had the audacity to do that in healthcare. And Henry Ford had the audacity and the courage to do that in the area of suicide prevention. And I happened to meet Dr. Berwick, and he was one of these receiving lines after a presentation at the National Council. And I asked him, I said, I bet you don't even know the impact you've had in zero suicide. And he immediately talked about Henry Ford. And he started doing his hands, and he was talking about hand washing. And I was like, wow, what's the connection? But that Saving 100,000 Lives campaign, it was about quality improvement and robust performance improvement. They went to the data. They began to tear it down into specific steps, and hand washing protocols related to hospital-based infections were the most significant low-hanging fruit to begin to save lives. And that's what Henry Ford has been doing time and again. So tremendous work. Brian, thanks so much for your leadership on this. And we're excited about the summit of bringing innovators together again in Liverpool this June.
Yeah, I think this roundtable has just been so fruitful discussion. And David, I'm so glad you mentioned healthcare associated infections, because that's part of value-based purchasing, right? And that financing piece, which is so important. And I forget which panelists brought it up, but the follow-up piece too is so critical. And I know with SAMHSA and the Lifeline Improvement Act that was passed last year, follow-up is now part of the Lifeline contacts. And so where it was voluntary before, or a different grant program, it's now embedded within the 988 Lifeline. So again, how are we bringing those things together? And it's happening, and it might not be perfect, but we're moving in the right direction. So with that, I'm going to bring in Carissa Pallas, who is the communications director for SAMHSA's 988 division. So Carissa.
Thanks, Laura. Hi, everybody. Happy to be here today. I just have a couple of very quick updates. Some of my colleagues, including Richard, this is why he's at the airport, were at the Policy Academy for Crisis System Design for States, Tribes, and Territories that happened Monday and Tuesday in Tucson, Arizona, to do some coalition building, talk about roles, application of systems engineering, design principles, and to develop and improve policies and practices in the design of crisis systems. So there should be more to come on that later. I'm sure they're going to go through and do a readout or something to share with everybody on outcomes from that. A couple of updates to share about the 988 Partner Toolkit. We've added some materials. I'm going to put the link in the chat in a minute. I also think there's a link on the Crisis Jam site if you don't get it from the chat. But we now have some bumper stickers. We've added some more usable branded photos. We have updated the ASL photos in coordination with our partners at DeafLead to make sure that they reflect the community in a better way. And we also have a new video that shows 988 and how it works and features some of the 988 counselors. So check that out. If you have a chance, please share broadly with anybody you know. Thank you.
Okay, thanks, Carissa. So with that SAMHSA update, we're going to move forward for our NASHBID update. So I'm going to ask Wendy Morris to share with us what's happening with NASHBID.
Great. Thank you, Laura. What a great program this has been today. So I want to talk for just a minute about, I'm going to give you an update on the Link Center. If you are a regular viewer, the Link Center was actually featured in episode 157, where you can get a pretty broad overview. This is a project of national significance designed to improve the care and supports for people with co-occurring mental illness and intellectual or developmental disabilities, head injury, other cognitive disabilities, or communication differences. It's funded by the Administration for Community Living, and key partner organizations doing this work are NASDS, the National Association of State Developmental Disability Directors, NASHBID, NAD, the National Association for Dual Diagnosis, and then we're also working with NASHA, the National Association of State Head Injury Administrators, along with a host of other partners who help us with quality improvement and keeping an eye on diversity, equity, and inclusion. And the exciting news today, if you can stay on, go back to the last slide for just a minute, is that we have just launched our website. This was just announced last week. We are putting the link to it in the chat for you to look at. Next slide, please. And I just wanted, these are just a couple screenshots so you can kind of see what to expect. A couple things I want to draw your attention to. It's pretty easy to follow. You can see we've got resources, announcements, how to access technical assistance, some information about our steering committee. If you look at the very top, it's almost impossible to see on this. Oh, look what David did. At the very top, you can see it says in crisis 988 Lifeline. And so we have a direct link to 988 because crisis services is a really important part of this work. So this screenshot here is our landing page. And the other thing I want to draw your attention to, if you look at upcoming events, is one place you can find it, but it's a link to register for our April Shared Learning Group. It's the third in a series. We do kind of a hub and spoke model. So there's 4 sessions aimed at 4 audiences, but it's the same topic. We'll be talking about transitions from hospitals, emergency rooms, psych hospitals to the community. One will be for clinical professionals, one for direct support workers, one for families, and one for individuals. You can go to the next page. This just focuses more on the resources. So if you were to go to resources link from the landing page, it's broken down into several categories. I'll draw your attention to the one on the far right at the bottom. It says crisis prevention and response. So that's where we kind of have those resources. Would love for you to look around this website. And if you have additional resources you think should be included, please let us know because we are still vetting resources to include. Next page. And then I just wanted to highlight this announcement. This was an announcement about our policy academy on inclusive 988 suicide and crisis response lifeline. This is actually funded by SAMHSA, which is really exciting. And we just did our kickoff in February. We invited 6 states to participate. We've had all our first round of state meetings and our first learning session. There's just some great work that's going to be accomplished to really move the system forward to be more inclusive. And we are very hopeful that this will just be the first of other opportunities for additional states. So you can read the release and find out more about it on our site. And I hope you'll take a look. Thank you. That's all I have today.
Thanks, Wendy. Again, we just have a number of really amazing conferences and opportunities coming up. So just appreciate you sharing that with us, Wendy. At this time, I'm going to bring in Brad Prendergraft, who is the Chief Clinical Officer at Protocol, to give us an update on the tech corner and AI usage. Brad, are you with us?
Jalen did hear you.
Absolutely. Hey, welcome. Thank you, Laura. So I'm here to talk today about generative AI, just a quick piece about ChatGPT. As Laura mentioned, I'm a clinician, not a technologist. So Dave Atkins, who runs the Tech Corner, asked me to speak as an example of a person in the crisis field who is using both organizationally and personally generative AI to really help with productivity, and in particular with training inside the crisis field. I'll be talking more about that at AAS. Would love to see some of you all there. So just have 5 minutes here. So my goal is to encourage you to be willing to experiment with generative AI, large language models. And the easiest way to do that is with ChatGPT these days. And to do that well, really, I need to do 2 things for you. One is I need to give you a understanding of what language models are, what people really mean right now when they use AI, or talk about using AI, what are the use cases, especially inside crisis work, and address lots of ethical and other questions. So I can't do that in 5 minutes, but fortunately, one of the leading thinkers in the AI field, Dr. Ethan Mollick from Wharton Business School, just came out with a book yesterday, and there is a interview with Ezra Klein in the New York Times from yesterday as well. And I think Karen's going to drop a link in there. It's a 30-day free link to that interview, and will really give you an understanding of a lot of those big questions. So what I'll do instead is to focus in on the use cases and on some of the very particular things that even someone without technical training, just using my clinical curiosity and my understanding of how important it is for our clients, for our callers, that we be able to use all the tools possible to help our organizations, what I've been able to do here. So I'm starting, I was going to start my timer already. I didn't, so I'll be watching here. So I'm going to share my screen here for a moment. And I encourage you, first thing to say is that I encourage you to get a paid account with ChatGPT. Oops, that's not the screen I meant to show. Hold on just a moment. Let's try this again. I'm going to share just this screen right here. Here we go. All right. So I use Chrome. I use Claude as well, and Gemini. If those things don't mean anything to you, that's okay. The most successful way to start experimenting with using generative AI is through ChatGPT. And I highly recommend you go ahead and use the $20 a month, just even on a 1-month basis, to get the paid version, because it's extremely superior. And in particular, what it can allow you to do, what I've been able to do, is to build single use cases of a ChatGPT, what are called custom GPTs. I'm going to show you how to do that. And all this means is that you can build basically an assistant that you provide your organizational information or your own information to it, and then it will basically work as an assistant with you. So here, if you're assuming you have a ChatGPT account, you go here to what's called Explore GPTs. You say you want to create one, and then it allows you to create instructions for what it should do and to give upload files so it will use your knowledge base, your organizational procedures and training, not just the general training. So what's the use of that? Well, let me show you a few use cases. Some of these are ones that we actually use inside ChatGPT, and others are ones that we've done as proof of concepts for our IT department to build out actually tools that all of our 400 employees can use, because we're not buying accounts for all of them. So for example, here is one called the Protocol Employee Handbook Guide. We have 400 employees. This allows our employees to ask any kind of question about what's in the handbook guide, just helps with the simple productivity. This is a part of a proof of concept for the larger app that allows, basically it's an API usage. If you don't know what that means, that's okay. It just means you don't have to pay for individual accounts. More specifically to our interests here online, this is what we call the Proto Training Guide. It's taken all of our transcripts of all of our training material and all of our policies and procedures and put it in the background, and it will tutor our counselors on issues they're struggling with, and it will engage in role play simulation, amazing simulations of crisis situations with our counselors, especially our new ones. So if someone's struggling with a particular issue, like let's say their supervisor says, well, you didn't do a good job on recognizing potential negligence for an elderly person on that call, they can come here, just put that in, and then it will create immediate simulations that will role play with them voice to voice until they get that issue down. Let's see. So just a couple other things to show you.
Brad, if I could interrupt here, because I think this is fascinating. And I say
All right,
that as a
Laura.
person with no technical background. But I think what we would really love for you to do is come back and give us a demo, because I think this is, at least for folks like me, who don't have a paid version of ChatGPT, like this would just be fascinating to see how this works. And also, I do want to highlight for folks, there was a AI debate a few, maybe months back now, that was highlighted on the Jam, that's on the YouTube channel, of just like, what is the role of AI here? So I think there's a lot we can mine here, but if you don't mind, I will, maybe let's save it for a following week.
So thank you, Laura. I know I was working to put a lot in real quickly there. So let me just wrap up and say to people, so what I would encourage you to do is to recognize that if you read things like the article that we'll drop in here, and it's aware out there, you can do a lot without actually being technologically trained, and can really help you and your organization's productivity and your clinicians' ability to do training. So thanks for letting me drop in, and I'd love to come back and do more of a demonstration for y'all.
Awesome. Thanks, Brad. And I see David already has here getting you on the full schedule. So let's make sure we do that. And I would love to have also maybe an update from SAMHSA, because there was some recent guidance from the White House around the use of AI. And so would just love to have maybe just a whole session on this. So love this work and glad that we're going to get this on the schedule. And thanks. There's the link to the chat to see the AI debate. So let me see, we should bring in next, speaking of government activities, Sarah Corcoran and Joanna Rosen from AFSP. What are some federal updates for us?
Thank you, Laura. We can switch to the next slide. The last time that we provided a federal update, we were eagerly anticipating release of the final package of 6 appropriations bills, including the labor HHS, including SAMHSA funding bill. That was released about a day after our last jam that we gave the update on, and it was signed into law early on Saturday morning over that weekend of the 22nd, 23rd of last month. We are happy to report that while there was a lot of concern that we could be looking at some cuts across the health funding space, that we see pretty level funding levels with the FY23 labor HHS appropriations bill that was signed into law towards the end of 2022, if I am remembering the dates correctly. We are looking at roughly level funding for SAMHSA at $7.4 billion, and the most notable increase in this within the agency is for the 988 Lifeline, and that is about an 19 to $20 million increase over what the FY23 level was. We've also got the listing of a few different programs here, and I will drop the link to the summary document in the chat for everyone to look at. But it's good news that the FY24 bills have all now been wrapped up, and we can look at FY25, which the process has already begun on the Hill. Joanna, I'm going to turn it to you. Thank you.
Sure, and I'll just pop in with a quick update. I know I saw many of you at the press conference about a week and a half ago on the Hill, at which the FCC chairwoman announced a new proposal to improve accuracy and access to care through 988 through geo-routing. So the FCC is going to be starting a rulemaking process, and we'll keep an eye on that as it continues. But I'll pop a little a press release from the FCC in the chat just so that everyone can read that. We're excited to see the prospect of geo-routing for 988 so that calls to the Lifeline are routed by local proximity to call centers rather than area codes, because we all know a lot of us have cell phone area codes that don't match where we live. And it's not always the most accurate resources being provided if you're reaching out and getting supports that are in an area that's not matching your area code. So I'll pop that into the chat. I know we're short on time, so Laura, I'll hand it back to you.
Thank you, Joanna and Sarah. Lots of great updates. glad to see increased funding there. So we have a special guest who is joining us, Sue Murray, who is again a legend in this space. I want to acknowledge that Sue is in, I believe, Australia. Is that right, Sue?
That's right.
And it is 2 a.m. right now there.
Something along those lines. Something along those lines.
Well,
Thanks, Laura.
thank you. Thank you so much for joining us.
No problem. Thanks a lot. So, you know, I guess it's hard for all of us to imagine that lifeline call centers were considered an innovation, but 60 years ago they were. And those phone lines are still providing very critical crisis support, but they're increasingly being complemented by other innovations in mental health care. And so this week in Crisis Talk, I had a chat with the Chief Psychiatrist from South Australia Health, Dr. John Brayley, to discuss some of the innovations that he's experienced over his career. Certainly for both Australia and the US, we've got vast areas of our geographies. They're sparsely populated. We've got harsh landscapes and difficult terrains. And so access to mental health care services that utilize technologies are really vital to get support into these difficult areas. And he talks a bit about telehealth as a critical player in the Australian landscape, and probably others, and that it's increasingly being used to provide that support where oftentimes there was little or even no access to mental health support. The other development that he talks about is the importance of non-medical services, those home-like environments that people can find a welcoming, safe space. They can de-escalate their levels of distress and connect with caring and compassionate support. These are the types of innovations that are meeting the expressed needs of the communities that we serve. It's taking them away from the bright lights, the noisy environments of the emergency departments. We also discussed those perennial problems that everyone is experiencing at the moment around workforce needs and data collection. And I am happy to say that Dr. Brayley, at least there is someone in this world who's got some optimism in this area, for particularly around the workforces, where he's seeing increasing interest in mental health nursing and psychiatry training. And I guess you'll have to read the rest of Crisis Talk to know what else he has to say. So thanks very much, Laura.
Thank you, Sue. I hope you get some rest. The link to the article is in the chat. And again, highly encourage everyone to go there, take a look, because there are some innovations, right? We've sort of got the contact lines and the phone, but let's think about it. And I know certainly Vibrant is, and SAMHSA as well, other ways that we can engage folks with the 988 Lifeline using other technology, social media means. So just thank you for joining us, Sue. Encourage everyone to go there. So we do have a couple of questions in the chat. I'm going to see if we have maybe a 30-second response from Richard, if you're still on the line, or Carissa from SAMHSA. I know there was a question around the Arizona convening. If you could just help us answer that one.
I'm still here. I don't know if Richard was still here. He would be the best to answer since he was there, but I will certainly try. And if not, we can definitely bring the answer back next week when we brief a little bit more about what happened.
Awesome. Thanks, Carissa. We'll look forward to that. And speaking of next week, we've got a great week, a great episode coming up. It is current events impacting LGBTQ people. Certainly, we know population at high risk of suicide, and that feature presentation will be Angela Weeks. So make sure that you join us next week. Thank you so much, everyone.